keep the discussion after the debate with Joseph. Joseph will present the magic rod in early onset scoliosis.
Thank you, Mohammed, and thank you. So, seeing that it's a debate, I will not show my cases because I've only had 3 of them. So, whenever someone talks to you about their experience with magic rods, unless your name is Behruz Agbania, you don't have much experience with magic rods. Okay? Most studies that you see about magnetic rods are usually multicentric, multinational to reach 90. And the most recent review article, about 500 patients head-to-head in last year, and that's from the last 15 years. So magic rods is a simpler construct. So the same way that he explained how you do a abdominal distraction, but instead of every time putting your patient to sleep, doing general surgery, anesthesia, neuromonitoring, going in, loosening the domino, distracting, you have a small machine inside, and that machine, there's a small magnet, and once you stimulate the magnet, the 2 rods distract. It sounds very simple. It has problems, but it's also beneficial in many ways. So the first actual study talking about magic rods, published by 2014 from the Growing Spine Study Group, which was led by Agbania, found that the curve correction was similar in both. Also growth, so T1, S1, and T1, T12 were similar, but magic patients had 57 less surgeries. And we'll talk in a bit, what does that mean for a child? So imagine a child having to undergo 6, 7, or 8 general anesthesia in a matter of 3 to 4 years. And complication-wise, especially unplanned surgeries, was similar, because a lot of kind of problems with the magic rods was that it's sometimes having complications with the actuator, with the rod breaking, with the tip breaking, but that kind of is offset. The most recent study is a 5-year follow-up, and that was published in 2025, so in September 2025. And they followed 92 patients, 54 traditional growing rods versus 38 magic. And they found more complications in the traditional, more revision with the traditional, and everything else, so health-related quality of life, pulmonary function, physical function, daily living, are all the same. What he mentioned in the end is economics, because yes, it is very expensive. But if you compare the expense, not in the beginning, but in the end, it pretty much sticks the same. So these 2 studies are studying how it shows. So, cost analysis. That means not only when you start your treatment, but when you end your treatment. And they found that cost neutrality at the 6-year mark. That means صح بالبداية بتدفع كتير بس لأنه you have less surgeries, less complications, less OR. In the end, they're pretty much the same. These 2 studies were kind of provisions. They're not actual patients' studies, but there was one that followed patients comparing traditional versus magic. And they found that in the beginning, the cost for magic, half the cost of the overall treatment was for the instrument itself. Imagine, نص الكلفة بس للماشين. But at the end, the cost effective was more than 40% less with the magic. Because, as I said, less surgeries. So instead of coming in doing 6, 5, sometimes 7 distractions, you do 1 surgery and then the final surgery. Complications. The main problem is that they were selling magic rods break because there's a lot of traction on that small machine and because it's stiff. So as he mentioned, you cannot bend it in the middle. So the junction between the rod and the actuator, that junction breaks. But they found that actually, this is also in 2025. They followed nearly 1,500 patients. And they found that rod breakage, whether for TGR or MCGR, is around 3%. However, TGR broke more than MCGR. So 5% versus 1.8%, because those also are under a lot of pressure and they break because that domino junction to the rod, and remember, he was doing a lot of bending of the rod. So those areas, the notching, makes it very susceptible for breakage. So another recent study, 2025, outcome. So we need to know at the end, is it better or not? Actually, they followed 550 patients, 400 to 140. Equivalence of both systems on X-ray. However, complications and return to OR were fewer in the MAGIC system. The total number of complications was less, the overall risk was lower, and implant breakage was less with MCGR, nearly 5 times less. So the traditional growing rods, not only you had to go to surgery to distract, but you had 5 more times riskier to go in to change your implant. And this is another review article about complications in general. They followed 23 studies, 127 complications. So 25% of MCGR had complications. It's a very high number. But if you compare it to the nearly 50% complication for TGR, it's at least half of the risk. Health-related quality of life is superior for MCGR, but the longer you follow up, in the end, it's pretty much the same. So, also, pulmonary function test, because the main concern with TGR for this MCGR is lengthening. So, المين problem تبعها إنه ما بيطولش العيان. That means the chest doesn't expand. So there's always an issue with pulmonary function test and T1 S1 length. They found that the data is not as good, whether for TGR or MCGR. The last thing I want to mention is this, and it's something we don't really talk about as surgeons because we don't really care. These are multiple studies about the psychological effect of repetitive surgeries. And these have multiple studies following how a patient having to undergo not 10, just 4 surgeries in a child between the age of 3 and 10, those children were found to have development issues in their brain and behavioral disorder and learning disabilities, to the level that US FDA highlighted the concern of repeated anesthesia. For one surgery, your risk of having ADHD, PTSD, problems with cognition, it was 1.1 times higher than normal population if you do one surgery. If you do 3 or more operation, that risk is multiplied to 4. So imagine the children that you're operating on 4 times, 5 times, 6 times. Imagine how that will affect their cognitive functions. So is it the answer? No, it's not the answer. It is one answer. So as he said, yes. Kyphotic patients, no. Small patients, big patients, no. But it is an option in patients that you don't need to reoperate for multiple reasons. Sometimes patients have cardiac issues, lung issues. You cannot do multiple anesthesia. So it is an option. Financially, it is a problem in the beginning, but it's like an investment. If you invest in the beginning, you get paid in the end, and eventually it pays off. Thank you.
Thank you, Joseph. So we are ready for any questions.
دكتور احمد، بس انا كنت بسأل، انت بتقول بتعمل ديستراكشن على الكونكيف وعلى الكونفكس، ليه بتعمل ديستراكشن على الكونفكس حضرتك؟
هو مش ديستراكشن، هو ايكواليزيشن. بس
الاكستراكشن صعب.
هو اكشولي الديستراكشن عنديش نيورون. هو it is hand. يعني just انك انت توصل لستريس بالذات في البدايه. عندك سيرجري عشان لسه الفاونديشن مش ماتيور انف. فديستراكت تو بالانس الشوطه. ولذلك الحمد لله الحاله الشوطه 100%.
لا انا كنت بتكلم على الايشو بس بتاع الكونفكس ديستراكشن بس.
احد اهداف القياس ان انت بتعمل لينثنينج. فانت you lengthen. I don't want to use the word distraction, but it is lengthening. We do differential distraction, more distraction on the concave side. The idea is not to correct by the growing rods the curve, but to keep it growing and lengthened. You usually at the end you are going to still do a definitive fusion and final correction of the curve.
So this is the difference between, for example, growth modulation, where you let the patient grow but direct. So this is the difference. So the debate was, what is the difference between growth modulation and growth lengthening? So growth modulation is you let the patient grow, you don't touch him, but you let one side grow slower than the other side. In TGR, you're actually distracting, but one side more than the other side. So you go in and you distract. So it is a distractive surgery. So every time you go in, you open, but on the concave, you distract more than the convex. But in growth modulation, one area you don't touch and let the other area grow more.